Last month, a patient walked into my office with a stack of pill bottles, 7 of them, all prescribed, all filled on time, every month, without a single missed dose. He was 71 years old, retired civil engineer from Denver, and he had been doing everything right, by the standard definition of doing everything right. And yet, 3 weeks before that appointment, he had spent 4 days in a cardiac care unit after what his emergency physician called a hypertensive crisis with early signs of myocardial ischemia, which, in plain language, means his heart muscle had been quietly starved of adequate blood flow until it could no longer compensate silently. What you have been told about the medications commonly prescribed after 60 is contradicted directly by the most recent evidence, and one or more of those pills may be doing something to your cardiovascular system that nobody has explained to you. By the time you finish this video, you will know exactly what the evidence documents, and exactly what to ask your physician the next time you sit across from one. Stay with me through to the end, because what I am about to walk you through may be the most important health information you encounter this year. The healthcare system is not structured to keep you well. It is structured to treat you after you are already sick. There is no billing code for prevention. That is not a cynical statement. That is how the system is built. And the evidence I am about to walk you through has been sitting in the medical literature for years. The problem is that it almost never crosses the desk at a standard 15-minute appointment. I'm Dr. Charles Whitmore. I started practicing in the early 2000s. What we believed about medication safety in older adults then and what the evidence actually shows now are two entirely different conversations. 20 years ago, the prevailing clinical consensus was that if a drug had been approved and a physician had prescribed it, the risk-benefit calculation was essentially done. What the last 2 decades of pharmacovigilance data have since documented is something far more complicated, particularly for adults over 60 whose kidney function, liver metabolism, and vascular architecture respond to these compounds very differently than younger patients do. I have spent the last 15 years reconciling that gap between what the prescribing guidelines assumed and what I was actually watching unfold in my patients. And tonight, I am going to walk you through the 5 medications the data most consistently flag as cardiovascular risks for adults in your age group. Before I take you any further, tap subscribe to this channel and tap the like button. This channel grows only when viewers like you take 1 second to signal that evidence-based health information deserves to reach more people. What I'm about to lay out, you will not hear in a standard clinic visit. Stay with me through the end, because the final medication on this list is one that most adults over 60 have either taken recently or have sitting in their medicine cabinet right now. A 2025 analysis published in Age and Aging tracked its cardiovascular footprint across a cohort of adults between 65 and 84 over a period of 6 years. The findings are, in the precise language of the investigators themselves, concerning. And yet, the prescription volume for this compound has continued to climb. That is what we are going to close with, but we begin at the beginning. Before I take you through these 5 medications, I want you to understand something about why this problem exists in the first place, because it is not simply a matter of bad prescriptions or uninformed physicians. It is structural. It is built into the way medications are developed and approved. Here is what most people do not know, and what I find genuinely important to state plainly. When the major clinical trials that support the approval of most common medications were conducted, the average trial participant was a male in his early to mid-40s. When you lay that demographic out next to the actual population consuming these medications most heavily, adults over 60, many of them women, many of them managing 2, 3, 4 concurrent diagnoses, the mismatch becomes unmistakable. The pharmacokinetics, which is the technical term for how a drug moves through your body, how fast it is absorbed, how the liver processes it, how the kidneys eliminate it, all of that changes measurably after 60. Think of it the way an engineer thinks about an electrical grid. A grid designed to handle peak loads of a certain voltage may run perfectly for 20 years. But introduce a different kind of load, one it was not calibrated to carry, and the circuit begins running too hot. Not immediately, not catastrophically at first, slowly, quietly, until one day a component fails. That is what I have been documenting in the data across 15 years of clinical work. And it is what tonight is specifically about. Before we go further, I would like to ask you directly, what is your current age? Your 60s, your 70s, or perhaps even older? And how many prescription medications are you currently taking? Write your age and the number of prescriptions in the comments. I read them, and what I consistently see there tells me how important this conversation is. Let us begin with the first medication on this list. The first category is non-steroidal anti-inflammatory drugs, what the medical literature abbreviates as NSAIDs, but what most people know by the household names printed on the bottles: ibuprofen, naproxen, and a range of prescription strength versions carrying different trade names. I want to be precise here because the cardiovascular risk of NSAIDs in older adults is not a hypothesis. It is one of the most rigorously documented findings in modern pharmacoepidemiology. Here is what is happening mechanically inside the body when an adult over 60 takes an NSAID regularly. These compounds suppress the production of prostaglandins, which are signaling molecules that, among other things, help regulate blood pressure, maintain the integrity of the stomach lining, and control sodium retention in the kidneys. Think of prostaglandins as a precision balance scale inside your vasculature, calibrated over decades to keep pressure within a narrow, healthy range. NSAIDs don't simply knock the scale slightly off center. They interfere with the mechanism that holds the scale in alignment. When sodium is retained, blood volume increases. When blood volume increases, blood pressure climbs. When blood pressure climbs in a vascular system that has already spent 6 or 7 decades accumulating stiffness in the arterial walls, the downstream consequences are not subtle. In February of 2026, investigators at the Cleveland Clinic published a review in Circulation examining NSAID-associated cardiovascular events specifically in adults over 65. The data documented a 45% elevated risk of major adverse cardiac events, which includes heart attack and stroke, in regular NSAID users compared to matched non-users in the same age group. 45%. The risk was not confined to high doses. It appeared at standard over-the-counter levels taken consistently over a period of weeks. The investigators noted specifically that the kidney-mediated blood pressure pathway was the primary mechanism driving the signal. I have documented this same pattern in my own patient population, not occasionally, consistently. What surprises patients when I walk them through this data is the same thing that surprised many of my colleagues when these numbers first began to accumulate in the literature. The assumption had always been that over-the-counter meant lower risk. That assumption does not survive scrutiny. The pharmacy shelf tells you nothing about your kidney function at 70. It tells you nothing about how many other compounds are competing for the same enzymatic pathways in your liver. Here is a detail most physicians never explain to a patient. NSAIDs also interact with several of the most commonly co-prescribed medications in this age group, including ACE inhibitors, diuretics, and beta blockers, in ways that can blunt their effectiveness and simultaneously push blood pressure in the wrong direction. A patient managing hypertension with a well-calibrated regimen of antihypertensives can find that regimen partially neutralized by a 10-day course of ibuprofen taken for back pain. The cardiologist who sees the resulting blood pressure numbers may not know about the ibuprofen, and the patient who reaches for the ibuprofen may not know it matters. Tonight, if you are taking an NSAID regularly, prescribed or over-the-counter, that is information your physician needs to have explicitly with the full context of your cardiovascular history. We will talk about specific steps before we close. But this is only part of the story. The second medication is one that fewer people recognize as a cardiac risk, which is precisely what makes it more dangerous. The second category is proton pump inhibitors, commonly known as PPIs. You may know them as omeprazole, pantoprazole, esomeprazole, medications prescribed for acid reflux, heartburn, and a range of upper gastrointestinal conditions. They are among the most widely prescribed drugs in the United States. They are also, in the geriatric population, one of the medications I follow most carefully in my patients. The cardiovascular mechanism here is indirect, which is part of why it has taken longer for the data to crystallize. PP is reduced stomach acid very effectively. In doing so, particularly with long-term use, which in clinical practice frequently means years, not weeks, they also impair the absorption of several micronutrients that are critical to cardiac function, magnesium, most notably, and vitamin B12. Magnesium is not peripheral to heart health, it is central to it. The heart's electrical system, the mechanism that coordinates each contraction, depends on magnesium as a kind of governing calibration system. Think of it as a timing mechanism, like a precision clock running a fraction of a second off. Over days, that barely registers. Over months, the accumulation means the clock is measurably wrong. In the heart, dysregulation of the electrical timing system, what the literature calls arrhythmia, or in plain language, an irregular heartbeat, is not a minor nuisance. In adults over 60, it is a significant independent risk factor for stroke and cardiac arrest. A study published in March 2025 in the Journal of the American Geriatric Society followed 4,213 adults over 65 who had been on continuous PPI therapy for a minimum of 18 months. Researchers found a statistically significant association between prolonged PPI use and incident atrial fibrillation, which is the most common sustained cardiac arrhythmia and a major contributor to stroke risk in this age group. The hazard ratio in that dataset was 1.38. In language that translates more directly, patients on long-term PPIs had a 38% higher rate of developing atrial fibrillation than comparable patients who were not on these medications. Now, I am not telling you that PPIs are never appropriate. There are genuine indications for these medications, and there are patients for whom the benefit clearly outweighs the risk. What I am documenting is the part of the conversation that typically does not happen in the 15 minutes a physician has with you. The review of whether long-term use is still warranted and whether your magnesium levels have been checked recently. In my practice, I order a serum magnesium level on any patient who has been on a PPI for longer than 6 months. It is a simple test. The result is frequently illuminating. Tonight, if you have been on a PPI for longer than 6 months without a recent conversation about whether it is still necessary and without a magnesium check, that conversation is worth having explicitly at your next appointment. If this has been useful so far, tap the like button. It is the single most important signal that keeps this evidence reaching more seniors. The third medication is one that I want to approach carefully because it sits in a category that patients frequently feel conflicted about: sleeping aids and anti-anxiety medications in the benzodiazepine class. Diazepam, lorazepam, alprazolam, and clonazepam are the most commonly encountered, and there are millions of adults over 60 in the United States who have been taking one of these compounds, in some cases, for a decade or more. The cardiovascular dimension of benzodiazepine use in older adults is distinct from the well-documented fall risk and cognitive concerns, though those are serious in their own right. The cardiac issue centers on a pathway that is less commonly discussed: the effect of chronic benzodiazepine use on the autonomic nervous system, specifically on what investigators call heart rate variability, or in plain language, the natural, healthy fluctuation in the timing between heartbeats. This variability is not noise in the system. It is a sign of a well-functioning autonomic cardiovascular regulator. Think of it as a pressure gauge that is supposed to make small, continuous adjustments. A healthy cardiovascular system reads slightly different measurements moment to moment because it is responding intelligently to everything happening in the body: posture, breathing, exertion, rest. Chronic benzodiazepine use appears to blunt this responsiveness. The gauge stops making those fine adjustments, and in a vascular system that is already operating with reduced redundancy due to age, reduced heart rate variability is an independent predictor of adverse cardiac outcomes. 20 years ago, in the early 2000s, the clinical consensus on benzodiazepine prescribing in older adults was beginning to shift. The Beers criteria, which is the American Geriatric Society's list of medications considered potentially inappropriate for adults over 65, had already flagged this class. What the evidence has since continued to document in the years since is a strengthening, not a weakening, of that signal. In 2026, the data consistently point to chronic benzodiazepine use as one of the modifiable cardiovascular risk factors in this population that is most underaddressed, in part because discontinuing these medications requires careful, supervised tapering and is genuinely difficult for patients who have been on them for years. I want to say something here that I do not say in every video. When I sit across from a patient who has been taking a benzodiazepine for 10 years, who tells me it is the only thing that lets them sleep or the only thing that quiets the anxiety, I do not present this information as a verdict. I present it as a conversation we need to have together with their full picture in front of us. The heart data matter. So does their quality of life. So does the reality that abrupt discontinuation is not safe. This is not a case for immediate action tonight. This is a case for a scheduled, unhurried appointment specifically to review this medication. Tonight, the action is to mark that conversation on your calendar and go into it informed. Which brings us to the fourth medication on this list, and this is where the evidence becomes genuinely remarkable. The fourth category is something that will likely surprise you, because it involves a class of medications that most adults over 60 associate almost entirely with allergy relief: first-generation antihistamines. Diphenhydramine is the most common. You know it better as the active ingredient in Benadryl, and in the sleep aid sections of every pharmacy under names like Ziziquil and Unisom. It is also found in many over-the-counter pain plus sleep combination products. It is everywhere. It is perceived as harmless, and the cardiovascular data on its use in adults over 60 tell a different story. Diphenhydramine belongs to a class of compounds that the literature describes as having anticholinergic properties, which, translated into plain language, means they block a specific receptor system in the nervous system that, among many other functions, helps regulate heart rhythm. In younger adults with robust cardiovascular reserves, this blockade is largely inconsequential at standard doses. In adults over 60, particularly those with any existing cardiac history, taking any antihypertensive or antiarrhythmic medication, it introduces a measurable and documented risk of QT interval prolongation. The QT interval is the technical name for a specific phase of the heart's electrical cycle. When it is prolonged, stretched beyond its normal duration, the window for a dangerous, potentially fatal arrhythmia called torsades de pointe opens. I have followed this data across the literature for years, and I will tell you what the pattern shows. The risk is not confined to overdose. It has been documented at standard doses in adults with baseline cardiac conditions that are common in this age group, taken in combination with other medications that are themselves QT active, and there are many of those. Certain antibiotics, certain antidepressants, certain antifungals. A patient taking diphenhydramine on a Tuesday night to sleep while on a course of azithromycin for a respiratory infection is combining compounds whose combined QT effect has been documented in case series. The patient does not know this. The pharmacist who filled both prescriptions may not have flagged it, and the physician who prescribed the antibiotic may not have known about the over-the-counter sleep aid. If you have been using diphenhydramine as a regular sleep aid, write yes in the comments right now. If you have not, write 0. Your answer helps other viewers see they are not alone in this. Tonight, check your medicine cabinet. Check every sleep aid, every allergy tablet, every combination cold and pain product. Diphenhydramine appears under many names. Read the active ingredient list, not the brand name. If it is there and you are over 60 with any cardiac history, that is a conversation your physician needs to have with you before you take it again. If what you've heard so far has been of value to you, share this video with someone over 60 whom you love, your parents, a sibling, a close friend. A single share can begin a conversation that might quietly save a life. Now we move to the 5th medication on this list. This is the one I referenced at the opening, and I want to take my time with it because it is the item I find most difficult to discuss. Not because the data are unclear, but because the population most affected by it is the population least likely to have been told about the risk. The 5th category is fluoroquinolone antibiotics, ciprofloxacin, levofloxacin, moxifloxacin. These are broad-spectrum antibiotics that, for decades, were considered among the safer options for treating urinary tract infections, respiratory infections, and a range of other conditions common in older adults. They are still frequently prescribed. And the cardiovascular data that have accumulated around this class, specifically in adults over 60, represent one of the more significant pharmacovigilance stories of the last decade. Fluoroquinolones are potent inhibitors of a specific enzyme involved in bacterial DNA replication. But like many highly active compounds, they are not perfectly selective in their targets. In the human heart, these medications interact with the same ion channels responsible for the orderly electrical repolarization of cardiac tissue after each beat. The result, in a subset of patients and a subset that disproportionately includes older adults with existing QT-sensitive conditions or co-medications, is QT prolongation of the same kind we discussed with diphenhydramine, but often more pronounced and faster in onset, given that fluoroquinolones are systemic antibiotics prescribed at doses calibrated to reach tissues throughout the body. Earlier this year, during a case review with colleagues at a clinic affiliated with Johns Hopkins, we laid out data from a retrospective cohort of 1,847 adults over 65 who had received fluoroquinolone courses in the preceding 18 months. The rate of new arrhythmia diagnoses in the 30-day window following each course was, by the language of the investigators in that room, statistically uncomfortable. It did not mean every patient who takes a fluoroquinolone will develop an arrhythmia. It meant the signal is real, it is consistent, and it is concentrated in this age group. There is a secondary cardiovascular concern with fluoroquinolones that has received significant attention in the literature since approximately 2018, when the FDA first updated its prescribing guidelines to include an explicit warning. An association between fluoroquinolone use and aortic aneurysm and dissection, which, in plain language, means weakening or rupture of the wall of the body's main artery. The biological mechanism involves fluoroquinolone-induced disruption of collagen and elastin, the structural proteins that give the aortic wall its integrity. Think of those proteins as the structural cables in a suspension bridge. The cables do not fail all at once. They develop microscopic weaknesses over time. If those cables were already under strain, as they are in adults over 60 with any history of hypertension, which is the majority, adding a compound that interferes with their repair and maintenance changes the loading calculation in a way that is not visible until it is. The FDA's guidance has been updated twice since then. The most recent update, issued in mid-2025, strengthened the language around use in patients over 60 with cardiovascular risk factors. The guidance does not recommend eliminating fluoroquinolone prescribing. It recommends explicit risk stratification before prescribing. a conversation about what alternatives are available and whether the indication genuinely requires this class. That conversation, in a 15-minute appointment, frequently does not happen. If you have been prescribed a fluoroquinolone antibiotic recently, or if you have a history of aortic abnormality, hypertension, or connective tissue disorders, tonight is the night to call your physician's office and ask specifically whether a non-fluoroquinolone alternative was considered. You are not second-guessing the prescription. You are participating intelligently in your own care. That is not just acceptable, it is appropriate. Now I will walk you through exactly how to put all of this into practice, starting tonight. The first and most important step is straightforward. Create a complete, current, accurate medication list, not a partial list, not a list of prescriptions only, every pill, every over-the-counter compound, every supplement. Starting tonight, go through your medicine cabinet and write down every substance you are putting into your body on a regular basis, including the ones you buy off a shelf without a prescription, the ones you take to sleep, the ones you take for back pain, the ones you have been taking for so long, they no longer feel like medications. They are. And their interactions with your prescribed regimen matter. They matter measurably. And the data I walked you through tonight are only possible to apply when that full picture is in one place. Within the next 3 to 7 days, contact your prescribing physician, not during a sick visit, not as an add-on to something else, and request a medication review. The explicit purpose of that appointment is to walk through your complete list and ask the following questions. Is each of these medications still indicated for me specifically? Have any of my prescriptions been shown to have cardiovascular interactions in adults over 60? Are there any QT prolonging compounds in my current regimen that need to be tracked? Do my kidney and liver function values at my current age affect how any of these drugs are being metabolized? These are not obscure questions. They are questions your physician can answer, but the appointment will not happen on its own. You have to schedule it. Within 2 weeks, ask specifically whether the following laboratory values are current: serum magnesium, kidney function markers, creatinine and GFR, liver enzymes, and a basic electrocardiogram to establish your current QT interval baseline. These are not exotic tests. They are foundational safety metrics for any adult over 60 managing a multi-medication regimen, and they should be reviewed at least annually. If they have not been checked in the last 12 months, ask tonight. Now, I want to say something that I take seriously every time I record a video like this one. There is someone watching this right now who has been on one of the medications we discussed tonight for years, who has been taking it without question because it was prescribed and because they trusted the system that prescribed it, and who is now carrying something in their chest, a concern, a question, a worry that they did not have an hour ago. I want to say this directly. The purpose of this video is not fear. It is not to make you distrust every pill on your nightstand. It is to give you the precise, specific knowledge you need to walk into your next appointment as an active participant rather than a passive recipient of decisions made about you. The evidence I have walked you through tonight is not fringe data. It is peer-reviewed, it is published, and it is the kind of information your physician should be discussing with you regardless of the time constraints of a standard appointment. Tonight, you have it, and that changes what you are able to ask for. Let us bring all of this together. We have now walked through 5 medications that the evidence flags as potential cardiovascular risks for adults over 60, non-steroidal anti-inflammatory drugs, and their blood pressure and interaction effects, proton pump inhibitors and their magnesium depletion mechanism connecting to arrhythmia risk, benzodiazepines and their suppression of heart rate variability, first-generation antihistamines like diphenhydramine and their QT prolonging anticholinergic activity, and fluoroquinolone antibiotics and their dual risk pathways involving cardiac electrical conduction and aortic structural integrity. Each of these carries its own weight in the literature. But what I want you to take away most is not a list of medications to fear. It is a framework for asking better questions, questions grounded in evidence that is now in your hands. Which of these 5 had you been told was safe for regular use without any additional conversation about cardiovascular risk? There is someone in your life, a spouse, a sibling, a parent, a close friend, who is over 60 and who is almost certainly taking at least one of the medications we walked through tonight, who has never had the conversation we just had. Send this to them. That one share might be the most important thing you do this week. One final note. Everything I have shared tonight is general medical information grounded in published research and years of clinical experience. Every person's situation is unique. Before making any changes to your medication regimen, particularly if you are currently on a prescribed medication, particularly if you have a cardiac history, particularly if you have kidney or liver considerations, have a full, honest conversation with your own physician. Do not discontinue anything unilaterally. That is not a legal disclaimer. That is genuine advice from someone who intends to keep you watching this channel 10 years from now and who understands that the correct use of this information is as a bridge to better conversations with your own care team, not as a replacement for them. Take care of yourself, starting tonight.